Today I am going to demonstrate how to deal with the patient having a hypoxic respiratory failure in COVID in the intensive care unit, and what should be the approach. This video is basically meant for just passed out MBBS students or interns who may be pushed into the service to deal with the COVID patients with hypoxic respiratory failure, and they may be presented for first time in their life with a ventilator and several type of devices to manage the hypoxic respiratory failure or hypoxia. At first, let us begin with the basic physiology of respiration and mechanics of respiration. It is most important part to know the basics of mechanics, because this is going to determine how you manage your patient with the help of ventilator or bag and mask. So at the beginning, what we normally do physiologically is something called as negative pressure breathing. What we generate is a negative intrapleural pressure by expanding the chest and creating negative pressure and sucking in the air from atmosphere. And as the chest collapses, we give the breath out, something known as expiration. Our brain determines how many times we breathe, how much time should be given for inspiration, how much time should be given for expiration, and what pressure should be, negative pressure should be raised in the chest during inspiration and expiration. As far as bag and mask is concerned or a ventilator is concerned, the process is exactly reverse. What we do here is something known as positive pressure ventilation, which is non-physiological. What we are doing here is that with the reservoir which allows the air and oxygen to mix to give a particular concentration of oxygen in this chamber, we are pressing this chamber and generating a positive pressure to push the air into the lungs of the child or an adult. So this is called as positive pressure breaths. So the amount of the pressure we generate is something called as peak inspiratory pressure. That maximum inspiratory pressure which we push the air into the lungs is called as peak inspiratory pressure. After giving the pressure, for how long you give the inspiratory pressure determines the inspiratory time. After that you release the bag. So this is expiratory phase. So the time taken for expiration determines the expiratory time. The pressure at the end of the expiration, if you release the bag totally, is zero. This is known as PEEP, peak and expiratory pressure. So if we give the inspiration and doesn't allow the bag maintain some amount of end expiratory pressure, it is known as peak and expiratory pressure. Now, what is the role of peak and expiratory pressure? That is most important. You take an analogy of a balloon, birthday balloon. If you are trying to inflate the balloon, initially you struggle to inflate the balloon, you have to generate lot of pressure. So your work done for inflating the balloon is too high initially. Once you inflate it little, with little pressure it keeps on inflating. Now imagine you have inflated the birthday balloon and allow it to deflate totally to zero pressure. The next breath again you have to put the same amount of exertion or pressure to inflate it again. So each time if you allow the lung to collapse totally and try to blow it out or expand it, you are generating lot of pressure and your work of breathing increases. What is the idea is allow the balloon to inflate. Then when it is deflating, don't allow it to deflate totally by keeping some amount of pressure at the end of expiration. That is known as peak and expiratory pressure. So that is the exact reason to decrease the work of breathing and to prevent the alveoli collapsing and opening again, which causes something known as atelectotrauma, which generates inflammatory mediators. So we do lung protective ventilation, that is known as open and keep it open. Keep it open by open it with peak inspiratory pressure and keep it open with peak and expiratory pressure. That is the basic physiology of ventilation. Now let us see the analogy of this bag and mask to this ventilator. What we are doing, this per minute is number of breath. So this is exactly reflected here. You can see the thing 40 here. This 40 is the respiratory rate and this 40 is the respiratory rate which I am giving the baby. Next comes inspiratory time. You can see the inspiratory time of 0.35 milliseconds. In adults, you give it up to from 0.75 to 1.5 milliseconds. In children, the respiratory rate is faster, so you keep the inspiratory time low. In adults, the rate is lower, so the inspiratory time gets prolonged to 0.75 to 1.5 seconds, whereas in children it is 0.35 milliseconds. So this is the time called as inspiratory time. This is the inspiratory time. Once I release the bag, baby goes in expiration. Once I press the bag and keep it pressed, this is the inspiratory time, expiratory time. So we have set the rate, we have set the inspiratory time, and then automatically the bag goes back and the baby goes into expiration. The ratio between inspiratory time and expiratory time is known as IE ratio. That is inspiratory-expiratory ratio. Normally in small babies we may keep 1:3, but in adults normally the ratio should be 1:2. So if inspiration time is X, the expiratory time should be 2X. So this is inspiration, this is expiration. The inspiration time is X, expiratory time should take double that. So we have done with the rate, we have done with the inspiratory time, we have done with the expiratory time. Then the amount of the pressure you exert on the bag is called as peak inspiratory pressure. This peak is the amount of the pressure which you exert on the bag. So this is known as peak inspiratory pressure. If you do this, then you are putting minimum pressure. If you do this, you are putting more pressure. You can see the thing moving. So if I am giving the breath, you can see the inspiratory pressure. At the end of the, if you do this, release this totally, you get positive and expiratory pressure which is 0. If you give inspiratory pressure and don't allow the thing to go to 0 and keep it pressed like this till you give the next breath, that is known as positive and expiratory pressure. That is known as PEEP. So now you have given PEEP, you are not allowing the thing to fully go back to 0, but you are keeping some amount of pressure at the end of expiration, that is known as peak inspiratory pressure. So from P peak, you know what is PEEP. So you do the settings of P peak and PEEP. So inspiratory pressure is 20 here. You can see this blue thing, and positive and expiratory pressure is 5 here. So now this is the, and there is an oxygen cylinder connected to this bag. So your FiO2 is determined by what is there in this. So this is cylinder, so this will give 100% oxygen because this is the concentrated. So what we do is at the back of the ventilator, if you see, there are two ports which are connected to the back of the ventilator. One is air and one is oxygen. So this air and oxygen goes at the back of the ventilator. There is something known as a blender inside it. If you see this machine here, another one, it has got a blender. This is known as a blender. So from the back of the machine, air comes, oxygen comes, this mixes the air and oxygen, and then it is sent to the patient through the tubing, and it goes here. So you can adjust your FiO2 on this. So you can, if you want 40%, 50%, you can want 100%, you can adjust it. This is known as a blender. So the ventilator has got a blender inside, it mixes oxygen, and you set the oxygen percentage required by dialing onto this. So now I am giving almost 62% of oxygen to the patient. Suppose if the patient is improving, I can decrease it to 40%. So these are the basic settings of ventilator. It is nothing but a bag and mask. I will repeat again. This is the baby lung. You are ventilating the baby. This is inspiration. When the lung goes back, that is expiration. Inspiration, expiration. If you don't allow to expire totally, this is called as PEEP, peak and expiratory pressure. Whereas this is PIP, peak inspiratory pressure. So peak inspiratory pressure, PEEP, peak inspiratory pressure, peak and expiratory pressure. If you allow it to go and go back totally, the peak and expiratory pressure is 0. Inspiratory pressure. So peak inspiratory pressure, PEEP, peak inspiratory pressure, peak and expiratory pressure. If you allow it to go back totally, the peak and expiratory pressure is 0. You decide the FiO2 on this, how much oxygen want to give to the baby through this oxygen port. Then with peak inspiratory pressure, you give the breath. When you release it, you get peak and expiratory pressure, and you can tighten the valve to adjust your peak and expiratory pressure. Plus, you have something called as safety features in the ventilators. So you can set your maximum pressure by this valve. This is known as pressure valve. It limits the pressure. You cannot give 50 centimeters of water to the baby, the lung, to the child. The lungs will burst. So as soon as you start pressing more, this is known as pop-off release valve. It releases the extra pressure and protects the baby. So same mechanism works in the baby. You set the limits for whatever you are doing, and you set the alarms to warn you. So ventilator is nothing but this plain M-loose bag. Inspiration, expiration, inspiration, expiration, inspiratory time, expiratory time, peak inspiratory pressure, positive and expiratory pressure, FiO2 through this, pop-up valve for protection, and sensors and alarms to warn you that you are exceeding the limits. That is as simple as that. That is the ventilator, nothing but bag and mask. So don't get overawed with the situation. Don't get overawed with the graphics and lot of things on the ventilator. But if you know the basics, you can ventilate. Anyone can ventilate on this ventilator. The second most important thing is that whenever you are ventilating, even with a bag and mask or a ventilator, your best parameter to gauge is a patient. Have a look at the patient, don't have a look at the monitors. Monitors may fool you. So if I take a deep breath, my chest bulges. If I breathe out, my chest goes in. Breathe in, chest goes in. So you look at the chest of the baby or chest of the patient. If the chest is expanding, it is rising, as normal person breathes, then you have done a good job. Then once it has risen up, it falls back to the normal as it would have normally fallen back in the normal patient. That is the thing, should be your peak and expiratory pressure. You can't have expanded chest and don't allow it to collapse and then keep on expanding. The air will keep on accumulating it, the lung will burst and you get pneumothorax. So keep a look at the chest of the patient. Breathing in, breathe out. Breathing, suppose this is the chest. Inspiration, expiration. Inspiration, expiration. You are doing a good job. Look for the color of the patient. Look for the pulses of the patient. Look for the blood pressure of the patient. If saturation is normal, pulses, tachycardia has come down, the color has come back, capillary refill time has come back, blood pressure has returned to normal, patient's urine output is good, that means you are a good job, you are doing good ventilation. Most important thing is don't allow to stack the breath. Allow the lung to expire, breathe out. So breathe in, breathe out, breathe in, breathe out. Don't do from here, breathe in, breathe out, breathe in, breathe out, breathe in, breathe out, breathe in, breathe out. You will cause collapse of overinflation of the lungs. Once the lungs are overinflated, cardiac output of the patient decreases because you are doing positive pressure ventilation, you are not doing negative pressure ventilation. Once the cardiac output decreases, the patient goes in shock. So you have to be very careful when you titrate your PEEP and PIP so that you do not cause trauma to the lungs, do not cause mechanical trauma, do not cause pneumothorax and do not cause decreased cardiac output. So this is nothing but easy method of ventilation. Now this is the last part of this video. Now we will understand about the gas exchange during ventilation, and that is the main purpose of our ventilation. We want baby to get oxygen and we want the baby to throw out carbon dioxide. So initial part is known as oxygenation. The second part of throwing out carbon dioxide is known as ventilation. So we have dual purpose: maintain oxygenation and throw out the carbon dioxide, wash out the carbon dioxide. That is known as maintain ventilation of the lungs. So the oxygenation is mainly function of mean airway pressure and FiO2. These are the two things which will decide about your oxygenation. If you keep on increasing FiO2, that is the percentage of oxygen delivered to the patient, your oxygenation will improve, your diffusion of oxygen will improve, and oxygen content of the blood will improve. Or in your saturations will start improving. That is one, by increasing FiO2. That is the easiest way to improve. The second way to increase the oxygenation is to prevent collapse of the lungs and keep them in, open them up and keep them opened up so that there is a good gas exchange. You can force the oxygen into the lungs and help the diffusion of oxygen by giving a pressure. So there are two ways to increase oxygenation. One is by increasing the concentration of oxygen which you are giving to the patient. Second thing, what you are going to do is the pressure, mean airway pressure. So mean airway pressure is determined by peak inspiratory pressure and expiratory pressure. So these are the two parameters which are going to decide your oxygenation. So if you increase the peak inspiratory pressure, your oxygenation will improve. If you increase the peak and expiratory pressure, your oxygenation will improve. In ARDS, we tried initially to increase the oxygenation by increasing FiO2 and peak and expiratory pressure. Normal peak and expiratory pressure in normal physiological lung is something between 3 to 4 centimeter of water. In ARDS, we keep on incrementally increasing by 2 to 2 till we reach 8 to 10. That is good enough for adults, around 8 or 10 in the case of ARDS to improve the oxygenation. So by increasing the PWP, you improve the oxygenation. By increasing the PIP, you improve the oxygenation. Now what about ventilation? Ventilation is a function of a tidal volume or a minute volume. How much air goes into the baby and air comes out of the baby, that is called as, with each breath it is known as tidal volume. So normal tidal volume which we keep on the machine is 6 ml per kg. That is the ideal tidal volume. Although the tidal volume from small children can vary from 4 to 8 ml, but the normal in adults and older children we try to keep 6 ml per kg as the tidal volume. So if you find that carbon dioxide is building up and ventilation is not occurring, not throwing out carbon dioxide, you have to increase the tidal volume. So you can increase the tidal volume by increasing the respiratory rate. So your minute volume increases, or minute volume is tidal volume multiplied by respiratory rate per minute. That the volume that is exhaled out per minute is known as minute volume. So it is tidal volume is exhaled per breath is known as tidal volume. So either you increase the minute volume by increasing the respiratory rate, or per breath you increase the tidal volume. So how do you increase the tidal volume? Suppose you have inspiratory and expiratory pressure like this. So this is inspiratory pressure, this is and expiratory pressure. If you increase the difference between two, so if you increase the peak inspiratory pressure, the tidal volume increases. If you decrease the peak inspiratory pressure, tidal volume decreases. So either you can decrease the PWP or you increase the PIP and increase the difference between PWP and PIP, and you will get more tidal volume. So that is the way you increase the tidal volume, either by increasing the respiratory rate or either by increasing the PIP or decreasing the PWP. So this is the basics of ventilation. Now if your patient is not maintaining oxygen on the room air and he is a COVID patient and you want to give him supplemental air, what are the methods which we have with us? Is the first method we use is free flow oxygen by mask. The amount of oxygen which we are supposed to give by free flow oxygen by mask is 6 to 10 liters per minute. If you give around 6 to 10 liters per minute by this mask, it has got holes all around. So half of part of it while breathing goes out through these holes. You can generate FiO2 of 35 to 60%. The percentage of oxygen you can get is 35% to 60%, or FiO2 of 0.3 to 0.6 with simple mask. If your patient is not maintaining with this simple mask, next you switch over and go on to something called as Venturi mask. So Venturi is nothing but you get these adapters which have got the regulators inside, and you fit this to the adapter, and this adapter goes and fits to this same different types of a mask. So what Venturi does is, when there is a high flow oxygen going to the narrow caliber, you can change the diameter of these inlets. So it creates high pressure jet, and there are side holes to to this adapter. So by it has got holes all around. So half of part of it while breathing goes out through these holes. You can generate FiO2 of 35 to 60%. The percentage of oxygen you can get is 35% to 60% or FiO2 of 0.3 to 0.6 with simple mask. If your patient is not maintaining with this simple mask, next you switch over and go on to something called as Venturi mask. So Venturi is nothing but you get these adapters which have got the regulators inside, and you fit this to the adapter, and this adapter goes and fits to this same different types of a mask. So what Venturi does is, when there is a high flow oxygen going to the narrow caliber, you can change the diameter of these inlets. So it creates high pressure jet, and there are side holes to this adapter. So by physics principles, it sucks in the air, room air, or it entrains the room air along with the high flow oxygen. So the amount of the entrainment will depend on the size of the nozzle. So these nozzles are marked with FiO2 60%, 50%, 35%, and the amount of the FiO2 which you can generate with Venturi mask is from 35 to 60%. So with plain mask, simple mask, you generate about 35 to 60%. With Venturi mask, you generate from 25 to 60%. Then there is something called as non-rebreathing mask. You must have heard most of the intensivists, when you ask them about your relative, how is he doing, he will say he was on free flow oxygen by mask, now he is not maintaining oxygen. We tried Venturi mask and we are not happy, and now he is on non-rebreathing mask. Non-rebreathing mask is this. It is just a special type of a mask with a bag attached to it. It is called, the patient breathes oxygen through the bag, and when he breathes out, there are side flaps which open up and which allows you to breathe out through the side flaps of the mask. So you do not breathe expired air, whereas you breathe pure concentrated oxygen through the bag. This is known as NRM, non-rebreathing mask. So the percentage of oxygen which you can get by non-rebreathing mask is almost 95%. So this will give you 35 to 60%. Venturi will give you about same 25 to 60%. Non-rebreathing mask will give you 90%. Once this fails, so from free flowing mask you have gone to Venturi mask, you have gone to the non-rebreathing mask, you have to resort either to something known as high flow nasal cannula oxygen or something known as BiPAP. Now, and if this fail, then you use this formula, something known as PF ratio and SF ratio. PF is PaO2 and FiO2. PF. So if you get suppose you get to on blood gases PaO2 of 70% and FiO2 of 1, you are using 100% oxygen, in spite of which your PaO2 is 70. So FiO2 by PaO2, so it becomes 70. When this value falls less than 300, that means your patient is in ARDS. If you rule out other causes, cardiac causes, especially on the patient who is on BiPAP or CPAP or ventilator, so we use PF ratio. Other thing is something the person will ask that I don't have a blood gas machine. How can I calculate the PF ratio? The easier way is you put a pulse oximeter and do saturation of on pulse oximeter and FiO2. So you get SF ratio. So SpO2 divided by FiO2, you get a SF ratio. If your SF ratio starts falling below 260, you know your patient is becoming bad. And if he has X-ray shows bilateral infiltrates and you have ruled out cardiac and other causes, your patient is most probably landing in ARDS. So we after free flow oxygen we use either simple CPAP or high flow nasal cannula oxygen. After that we use BiPAP machine. In BiPAP machine you give dual pressures. You give peak inspiratory pressure and expiratory pressure. So you get something known as IPAP and BiPAP, EPAP. So IPAP is inspiratory positive airway pressure and EPAP is expiratory positive airway pressure. So you are giving inspiratory pressure, allow the patient to breathe, but don't allow him to go to zero, you keep expiratory pressure. So BiPAP has got two components, inspiratory peak airway pressure. Majorly BiPAP is the airway pressure. So inspiratory pressure is IPAP, expiratory pressure is EPAP. So when you have IPAP and EPAP, it becomes BiPAP. So in the next video, we will actually see how to twiddle the knobs on the ventilator and what are the things which you monitor on the ventilator. Thank you and have a good day. Stay safe. Good night.